Hi, everyone. Thanks for joining. We're just going to give it a minute to let people come in. So it's a couple minutes after. I think we're going to go ahead and get started. Thank you for joining us for this National Echo session. And this is the first of what we plan to be a series of sessions around the topic of pediatric palliative care. So this is our first session, so I'm really excited to kick things off and um, really pleased to welcome Dave Lysecki and Kira Goodman. So they're going to be focusing on the topic of pediatric palliative care, specifically, how can you play a role? Okay. And one of the things I wanted to do just before we get started is just to acknowledge the territory where I'm presenting from, which is the Mississaugas of the Credit, Anishinaabeg, and Chippewa, and Haudenosaunee, and the Wendat peoples. This is covered by Treaty 13 and the Williams Treaties and remains home to many First Nation, Inuit, and Métis people. And I would ask that as we all gather here from different parts across the country, that we just take this moment to recognize these treated and unceded lands. And I'll invite Dave and Kira if you wanted to add anything to that.
I would like to add I'm on very similar territories, Toronto to Hamilton, but so the traditional territories of the Haudenosaunee and Anishinaabe people. Um, and having had Truth and Reconciliation Day recently pass and Orange Shirt Day, I hope we all took time to reflect on the atrocities that occurred in residential schools. And when we think about pediatric palliative care, one of our big focuses is about equity of access to pediatric palliative care across this country. And that means bringing care into homes and communities across this country. With residential schools, children were forcibly taken from their homes, taken into Western institutions, and died there and never returned to their home or community. Although the intention is different, the same is still occurring in healthcare. Children are forcibly removed from their communities to access the type of care they need, often found in tertiary pediatric hospitals. Many of those children do not return home to their families or communities because of their medical needs and end up dying in hospitals. And so it's really a moral imperative that we ensure that children of all backgrounds, Canadians and new immigrants and visitors to Canada can receive care where they need it most, which is in the loving arms of their family, surrounded and supported by the community around them. And so I hope we can carry that mentality forward into this care to really come with a problem-solving notion of how do we make this happen instead of assuming that, you know what, someone else will do it. The care needs to be done at the children's hospital. The children will go there and they'll receive the care and remember about the generational trauma and how that can be particularly triggering for our First Nations allies.
Dave, don't have much to add to that. I think you captured that really beautifully. But despite the fact that I'm usually in Toronto, I'm currently in Ottawa at Roger Neilson Children's Hospice. So I just wanted to acknowledge I'm on the unceded, unsurrendered territory of the Anishinaabe and Algonquin Nation, and really grateful to be here with all of you from across the country to speak about this important topic on National Children's Hospice Palliative Care Day. So I will mute myself and you can move on.
Thank you, Kira. Thank you, Dave. There are a few little boilerplate or housekeeping slides at the beginning. I'm going to try to whiz through those and so we can really get into the meat of the project. But this is all, provided or brought to you under the umbrella of the Palliative Care Echo project. So just like this session, there's lots of great educational sessions, usually an hour long, totally free of cost that you can register for to attend live or even just watch recordings at your own time when it's better for you. So if you haven't yet checked out the website, the link is there. It's echopalliative.com, and you can take a look at what we have available to you. Also, at this time, I just wanted to highlight one of Pallium Canada's, I don't know if cornerstone programs is the right word, but I wanted to highlight LEAP, if you're not familiar with it. This is an award-winning course that was built to transform healthcare practice by building skills and confidence to provide compassionate, patient-centered care. It's developed and peer-reviewed by Canadian palliative care experts, grounded in the evidence and best practices. And we have many different types of courses tailored to different care settings or different patient populations. So what might be relevant to people joining us today is LEAP Pediatric. So if you want to learn more about these accredited courses, you can check them out at pallium.ca/courses. Okay, so I am Holly Finn. I'm the Senior Manager of Program Delivery. I'm your host for today, and I think it would be great for the audience to get a little glimpse into our presenters. So if you can introduce yourselves, let us know a bit about your background. I'll hand it over to Dave.
Thank you. So my name's Dave Lysecki. I am a pediatric palliative care physician at McMaster Children's Hospital. So I trained in pediatrics first, then pediatric hematology oncology, and then pediatric palliative care. And I work here at McMaster Children's Hospital and McMaster University. I am the medical director for our future pediatric hospice, Keaton's House Children's Hospice, which should be opening in 2027 in here in Hamilton. And I'm the medical director of Canada's Pediatric Palliative Care Alliance, where I work very closely with Kira, and so she will introduce herself.
Thanks, Dave. I'm Kira Goodman. I am the project director for Canada's Pediatric Palliative Care Alliance, which we'll tell you a little bit more about later. I'm a registered nurse by background. I worked in labor and delivery for most of my frontline career before going back and doing an MBA. And I've been doing project work for some time now. I worked with the pediatric advanced care team at Sick Kids for a while as their project manager, and then worked as the manager of Emily's House Children's Hospice, which is located in Toronto, for about a year and a half before moving on to this project. And that's me in a nutshell.
Thank you. And we're nearing the end here, I promise, of the intro slides. I just want to encourage you guys, you're welcome to add comments. You can introduce yourselves. It'd be really cool for us to all to know where you're joining from, what's your role, what's your care setting, what's your hobby, whatever, anything. We'd love to get to know you better. And for questions, please, if you can remember, try to add those to the separate Q&A function, because that way, when it comes time for Q&A, we can easily pick out the questions that you have for our presenters. This session is being recorded, so if for some reason you have to leave early, or for those who didn't make it during the session live, we will be sharing the slide deck and the recording within about a week's time from this. Yeah, if you're asking any questions or anything in the chat, just remember, if you're talking about cases, not to disclose any personal health information. And sorry, I lied. There is a disclosure slide. There's no conflicts of interest from Dave. I wanted to mention that as I did earlier, I'm employed by Pallium Canada, and Kira's work is funded by Health Canada. Whew. Okay, Dave, it's all yours.
Okay, and thank you for those adding in who you are and where you're coming from. We will wish to make this content as relevant as possible for the audience, but one of the premises that this topic is relevant to everyone, whether you know it yet or not. So we want to explore how everyone has a role to play in pediatric palliative care. And to ground us in clinical practice, we're going to start with a case that is, of course, made up. But Jerry is a 13-year-old with relapsed metastatic hepatoblastoma and trisomy 21. Jerry likes fishing, and more fishing, he'll tell you. He's cool, very friendly, very interactive, but he gets dysregulated very quickly and aggressively with particularly triggered by pain, secondary to traumatic medical stress following a significant ICU admission for a liver surgery post his surgery with substantial delirium during that admission. Jerry has a portacath in place for his chemotherapy. He has a G tube that's been used for nutritional supplementation. He is on methadone for bony pain, mirtazapine for anxiety and some of his behaviors. He's getting oral palliative chemotherapy and is still on and is receiving infection prophylaxis with Septra and fluconazole, as he's particularly susceptible to infections. Now, before I move to the next slide, I just want to highlight that Jerry might seem quite complex, maybe even to some people exaggeratedly complex. And I can tell you, working in pediatric palliative care, that Jerry is not particularly different than 4 or 5 patients on my inpatient list right now, in that many have multiple diagnoses where conditions like trisomy 21 or other conditions may increase your risk of cancer or seizures or significant cerebral palsy, et cetera, et cetera. Many children with medical needs have developmental and behavioral considerations alongside their significant medical needs. Many are on, the average, one study looked at pediatric palliative care patients, the average was on 11, the average was 11 medications per patient. Many have medical devices. In that same study, only 20% of pediatric palliative care patients did not have medical devices. So this is very routine for us to be balancing multiple aspects of medical complexity. Jerry's from rural Ontario, and he spent most of the last 2 years in Toronto, receiving his oncology care there and surgeries, etc. Uh, at this point, as now the oncologists have told them, there is really no further aggressive therapy that they expect to decrease the size of his tumors, and rather the best they can do is keep them at bay with oral chemotherapy. Jerry and his family really have expressed their desire to spend as much of their remaining days as possible at home by the lake. So when we think about pediatric palliative care, we have a significant number problem, and it is both a problem and a benefit, which is that thankfully pediatric serious illness, pediatric death is by serious illness is a relatively rare phenomenon, much rarer than death in adults. So if you looked at if you look at death data across Canada and as an extension, death with as a result of a serious illness, children represent about 1% of all deaths in Canada, 1% of all palliative care. So pediatric palliative care is approximately 1% of all palliative care that occurs in Canada. Similarly, children with palliative care needs are about 1% of all children in Canada, a little less. And so as a result, we have a significant overlap. Sorry that this slide came out a little blurry, but a significant overlap of rarity. So having gone through a pediatric residency, I can tell you that much of that time is spent, learning ADHD and treating bronchiolitis and studying children's developmental ages and stages, and not focused on end of life care. In fact, most pediatric trainees will finish their training having never done a home visit for a child with significant medical complexity. Similarly, as children represent only a small proportion of all individuals requiring palliative care, many palliative care clinicians have limited exposure, if any, to children and providing that care. And there are studies that where they've expressed a discomfort, but a willingness when supported by pediatric palliative care services. And so this overlap highlights a problem in palliative care and mapping palliative care onto pediatrics, which is that I know at least in my region alone, there is a great variety of palliative care models, depending on your community models, where it's really family health team based, and palliative care specialists or specialty services are either non-existent or really only provide consultative level care. Other areas where palliative care is a very takeover, and it's like, well, once the patient's, has substantial palliative care needs, then hand over and we've got it from there. And so what can happen with children is that if you start with the family health team says, oh, I haven't seen this patient in years because they've been going to their pediatrics specialist or pediatrician. Go ask them. You go to pediatrics and they say, well, I don't do palliative care. I certainly don't do home visits. Go ask palliative care. You ask palliative care, and if it's in a consultancy model practice, then they may say, oh, you got to take that to the family health team, and around the circle we go. Um, so when we think about palliative care, palliative care is very proactive care. It is thinking in advance of what are Jerry's needs now? What are Jerry's family's needs? What will be their needs over the course of his next journey, and how can we prepare for those, particularly in his home setting, in a way that we don't need to do it necessarily. We ought to do lots of preparation. We don't need to do as much preparation in hospital because we always have things available to us. We always have a pharmacy nearby. We always have a crash cart. We have things in arm's reach, but planning for care in a rural environment requires quite a lot of proactive thinking. So for Jerry, he requires health maintenance care. So things like his basic nutrition, his antibiotic prophylaxis, constipation management. He needs a plan for his oral chemotherapy, which is mainly oral, but it requires checking his blood counts. It requires a fever management plan. If he gets fevers, he will require someone who can do a CBC and look to see if he's neutropenic and draw a blood culture and assess his stability and decide whether he needs admission or to stay home or can go back home. He needs central line care, which means accesses and flushes. Him and his family need mental health support. That might be counseling for Jerry or counseling for family members. He certainly needs support for his anxiety, his PTSD, and someone to manage the mirtazapine. Thinking forward, he's currently on methadone for pain. It's very reasonable to expect an increase in his pain as his disease progresses, and that's going to require thoughtful care. If truly they want to spend as much time at home as possible, then trying to obtain as much in-home care as possible is going to be important, including and very importantly, ensuring the accessibility of that home, as Jerry is very likely to lose some of his physical functions in the weeks and months before his death. Having 24/7 support is going to be critical to keeping them at home to problem solve with them. Someone to help facilitate, coordinated all this care. At the time of death, having someone available to pronounce and work with the family through funeral planning and discussions around organ donation. Somebody supporting his siblings, supporting his parents, and someone supporting the staff, many of whom may not have much experience with pediatric palliative care, and the emotional journey that it will go through, that they will go through caring for Jerry and ultimately supporting Jerry through his passing. When we think of these needs, that you can bucket to some degree the needs into, let's say, medical categories, these daily care needs, coordination needs, psychosocial financial needs, emotional needs, spiritual needs, and grief and bereavement needs. And you can take many of those tasks that need to be done and map them onto these needs or crossing some of the needs. But we need people, teams to help support directing treatment. We need to support the family. We need to support his school and the school environment if he's going back to school, which may be something that he's really excited for, being home and seeing some old friends. It may be transportation, it may be parent support, it may be funeral planning. These are all sort of categories of needs that this family has. And if you if everyone said, you know what, I can't look after all of Jerry's needs. This is all too much. But what role can I play? How can I come to the table? How can I show up for Jerry and his family? What is in my comfort zone? And how can I bring that to a broader care network? You could look at these tasks and really look at some of these health maintenance issues, supporting the family with housing and transportation and providing continuity and providing care to the whole family. Like maybe there's a lot of comfort within the family health team with a lot of these issues, and whether it's a physician or a nurse practitioner or both or a extensive family health team, they may say, hey, yes, I'm willing to come to the table and I want to do these things that are in my comfort zone. Whereas the, pediatric specialists, in this case, perhaps oncology specialist, maybe a general pediatrician that's even community based, may say, you know what, for intercurrent fevers and in terms of working him up for potential infection, maybe treating fever and neutropenia, maybe diagnosing new issues as they arise, like bowel obstructions, etc. These are things that are in my comfort zone as a pediatrician or a pediatric specialist, and this is how, this is what I can bring to the table and how I want to play a role. I might not have comfort with managing the methadone, but I certainly have comfort with talking to the family about, where I think his disease is going based on his clinical progression. Whereas, and then in palliative care, there are lots of things that are germane to palliative care, things like funeral planning, things like advanced symptom management, whether it's methadone or a fentanyl infusion, or things that we have comfort with, things like planning end of life care at home, supporting families through legacy creation and grief support. These are all things that people in palliative care are very used to and very comfortable with. When you ask any individual clinician whether they're willing to take Jerry on alone, it may seem very intimidating and too much. But when you ask people to say, "Hey, can we all come together, put our heads together, see what aspects of his care, what tasks are within our comfort zone, and perhaps together we can develop a map that covers all of Jerry's needs." And in the middle of that is care coordination, which is a really important role to being able to make this happen. And this is where much of pediatric hospice palliative care specialty teams play a role in rural settings, although we may be primarily based at the children's hospitals, but we can help be there to connect individuals across different sectors, to provide guidance for what to expect and what treatments may be considered, to provide 24/7 backup support. And so really in pediatric palliative care, to make this happen for children, what we're trying to do is build a network around them. Some people use the term a nest around them, where we know that the child and family is at the center of this care circle, and we know that they have these needs that often requires some medical support, either physician, nurse practitioner, both, some nursing support, ideally home visiting nursing, maybe at a nursing station, maybe at a local community hospital, requiring case management. Sometimes there are resources in communities or through home care agencies that can provide some of that. Sometimes that needs to be done through the specialist pediatric palliative care team, who represent this yellow ring of support around local regional supports that can be found. Whether there's a social work support or not available in the community, maybe through the family health team, child life and psychology, if those resources are available at a community level, great. If not, those may be tasks for the specialist team to play, but the specialist team can provide sort of this wraparound support to fill in some of these gaps. And so for Jerry's needs, what this might look like is if home care nursing can be established, or regular visits to a nursing station, those might be able to be people that have eyes on Jerry and are checking in, able to do pain assessments, support with some of his daily care needs, perhaps. Perhaps through this process, the family health care team says, you know what, we are certainly going to continue to provide care for the parents and siblings. We want to lead that part of the work now because we're going to just continue it throughout the course of their life. Maybe we can do home visits, maybe not, depending on the circumstances. We do have 24-hour line, and so we're happy to be their first call to help manage issues. We're certainly happy to go into the home and do pronouncement. Again, this is hypothetical, and different networks will require different solutions from different people. But in this example, perhaps it's the family health team that says, you know, we are willing to take on pronouncement, and we're willing to support the funeral, perhaps with a psychosocial clinician in the team that help the family with funeral planning. Maybe the local hospital has some pediatricians that have said, you know what, we in consultation with the pediatric oncology clinic and the pediatric palliative care program, you know, we're happy to take the lead on his nutritional planning, on his constipation plan. If he develops a fever and routinely related to his chemotherapy, we're happy to check his blood counts. And if he needs admission for fever and neutropenia, based on the family's goals of care, we're happy to do that and lead the portacath care in terms of orders and ensuring it's looked after. Maybe there's a palliative care clinician that says, you know what, I want to come to the table. I'm happy to do methadone and write those prescriptions and evaluate the pain and start there and see what his pain story is as it goes forward. And maybe there's going to be more of a role for this person in the future, possibly not. The pediatric palliative care team, there may be things that, despite, you know, developing this network, there may be things that are either outside of people's comfort or simply not locally available resources. So maybe counseling remains with one of the members of the pediatric palliative care team virtually, that between that psychosocial clinician and the pediatric palliative care physician, maybe the decision is that we'll manage and monitor the mirtazapine because it's an unusual medication for other people in this support, that we're going to offer 24/7 backup support to everybody in this network so that there's a 24-hour phone number to talk. And we're going to provide pre-brief sessions and debrief sessions to support these clinicians who are gradually developing emotional attachments to Jerry and his family, and are really feeling the emotional struggle of providing end-of-life care to a child. And the pediatric oncology clinic virtually will continue to manage his chemotherapy. So if we all come together, we can provide Jerry's needs. And the same is true of it. Many people think pediatric oncology, when they think pediatric palliative care, and much of pediatric palliative care evolved out of pediatric oncology. Pediatric oncology represents somewhere between 10 and 20% of pediatric palliative care done in most pediatric palliative care programs. But this same approach and model could work for the 17-year-old with cerebral palsy who has severe scoliosis and recurrent aspiration pneumonias and is on their way to a death by chronic respiratory failure as a result of chronic daily microaspiration and lung damage, a common pathway for children and young adults with severe neurologic impairment. A 12-year-old with Duchenne's muscular dystrophy and autism spectrum disorder, commonly comorbid. A 4-year-old with a new diagnosis of Batten syndrome, which is a progressive neurodegenerative disorder. A 1-week-old, 24-week gestational infant with ventricular hemorrhage in the NICU. A 6-month-old with infantile spasms, and a 21-week fetus with trisomy 18, where the family needs much of the same support as they make plannings through their pregnancy, their birth planning, and their grief afterwards. So the better we can create these care networks in communities, we want, most of us in pediatric palliative care programs want to empower our community partners to be providing as much of this care as possible, particularly those that can offer the family continuity after the fact, such as the case in family health teams, and through great organizations like outreach palliative care programs and community hospices, and many of whom have grief programs that they're able to stay connected to the families with. And the more work that can be done by primary providers, it does free up then the specialist providers to look at big projects like advocacy and awareness and education and quality outcomes and staff support and research. And that's a little bit about what Kira is going to talk about now. So I'm going to hand over some of this more the non-patient facing side of pediatric palliative care in terms of how we can empower community providers to provide the care.
Thanks, Dave. Thanks, everyone. So I'll tell you a little bit about Canada's Pediatric Palliative Care Alliance. So back in 2018, Health Canada released their framework on palliative care. And when they were doing their 5-year review back in 2023, they spoke to Roger Neilson Children's Hospice leadership here in Ottawa, who shared the work they were doing, collaborating with other centers looking to grow and build new programs in hospices. That sparked an idea that led to a grant proposal that was ultimately approved. When that happened in late 2023, we began the project by spending months engaging people across the country who work in pediatric palliative care, those who work day to day in this space, as well as those who have maybe done this once or maybe have never done it before because it feels too overwhelming, as Dave was speaking about today. And we found that one thing was really clear across all of those spaces, that there really isn't a coordinated voice or a clear place to go to learn about and to advocate for pediatric palliative care. So in addition to focusing on our core project deliverables, which you can see here, were the development of a bilingual resource hub, which is geared towards supporting healthcare professionals in delivering pediatric palliative care, building a network for practitioners. So instead of just having a bunch of documents on a website, how can we bring people together in real time and asynchronously to be able to learn more? And developing a shared vision of what high quality pediatric palliative care means across Canada. So in addition to that, we also launched Canada's Pediatric Palliative Care Alliance 1 year ago today on National Children's Hospice Palliative Care Day. And the overarching vision is a future where every Canadian child with a serious illness has access to high quality pediatric palliative care, regardless of their location, their background, or their circumstance. The key players so far have been Health Canada as our funder, Roger Neilson Children's Hospice, who acts as our kind of project home and infrastructure, our little project team, but really it's our key collaborators, which are healthcare professionals, families, and organizations across the country that have really helped bring the Alliance to life. I'm going to tell you a bit more about pediatric palliative care as it is now. So these slides kind of build on each other. So what you're seeing here is a little bit of an understanding of what what the population distribution is here in Canada. So when we look across Canada, we have about 8.6 million children and youth under the age of 19. Sometimes we even include up to 24 when we do these estimates, but still a significant number. And as you can see, it's spread across all of our provinces and territories. And it's important to understand this distribution because, as Dave said, pediatric palliative care is relevant in every region across our country, whether you're urban, whether you're rural, or whether you're remote. So when we build on this by layering on top how many hospices we have, and I apologize, I noticed afterwards that I have 8, and then on the second little green bubble there is a 7, but we have 8 children's hospices currently in existence spread across our entire country, with 2 more in the advocacy stages, one of which is in Ontario, one of which is in Nova Scotia, and 2 more in the approval stages, one of which is in Ontario and one is in Quebec. So for context, the UK, which has a very well-developed palliative care presence, has more than 6 times the number of hospices with only double the population. So we can see that we do have an underdeveloped pediatric hospice infrastructure here in Canada. And for most families that want a children's hospice, either for respite, symptom management, or if it's their location of choice for their child's end of life, they have to travel significant distances to be able to access this specialized care, and often out of province and territory, making it really not a great option for a lot of families. So if we layer on top of that, our hospices and hospital-based teams that exist across the country, it gives us an even fulsome picture. So on top of these hospices, we have a hospital-based program. So in total, we have 18 hospital or hospice-based or combined programs across the country. Most of these are located, all of these are located in urban centers, predominantly along the southernmost border of Canada, other than the one team that's up in Edmonton. What's interesting about these programs is that even within them, there are significant inequities. So the size and the composition of these teams vary significantly. Some teams have really close to 1 full-time equivalent, while others have all the way up to close to 12 full-time equivalents. And appreciating that, obviously, we have to take into context the population that they're serving. Regardless of that, they're also all struggling with stable funding mechanisms, and most of the teams are funded through research grants or short-term projects or fragmented hospital support. So really, truly an inequitable distribution across the country. And for families that don't live near these specialty teams or hospices, they're relying on local resources, which vary very widely in availability and in their quality. A lot of these teams and hospices struggle to sustain 24/7 coverage, which leaves families and healthcare professionals with limited experience in this area without the support that they need to be able to step in and provide care for these families. So that further perpetuates the lack of access of essential pediatric palliative care, especially at the most critical of times. So there we go. Pediatric palliative care itself, as Dave had said earlier, is statistically rare. So we know it's less than 1% of all palliative care is care that is delivered to children. And as a result, we end up with not prompting careful planning, but leading to invisibility in a lot of health system planning. So that means that PPC or pediatric palliative care is rarely recognized when we're planning funding, when we're planning training, and it remains very under-resourced and in a lot of spaces very poorly understood. This trickles down into the way that care is delivered. So at present, our most recent national standard for pediatric palliative care is from 2006, although we're excited to say at present there is a new standard in development through the Health Standards Organization that will cover all populations need pediatric or that need palliative care. So excited to say that soon we'll be speaking about a more recent standard. But training is inconsistent, roles are unclear, and many families and teams are forced to adapt to adult frameworks that don't fit. So we end up with these under-resourced teams. And as a result, families from all communities tell us that the care that they're getting is based on where they live, not on what they need. So we're not looking at a patchy implementation of a robust system. We're looking at a structural system level issue in the way pediatric palliative care is designed and delivered. So we did do through the Alliance a literature review that was published a little bit earlier this year that echoes a lot of what I'm sharing with you today. It found very similar issues, and the way that we ran this rapid review was we looked at international pediatric palliative care and framed it through a Canadian lens to see where there were similar challenges and where there were solutions that we may be able to lean into. So the literature shows unclear roles, lack of expertise, fragmented systems, poor coordination. It also points to solutions such as consistent education, national practice standards, better access through 24/7 support and regional networks, and of course, ultimately an increased awareness that pediatric palliative care and all palliative care is not just end-of-life care, but it is quality of life focused care. And these are the needs that we at Canada's Paediatric Palliative Care Alliance are actively working to solve. So what we did is we mapped the evidence that I just spoke about onto the actions that we're taking. So what's exciting is we're not just identifying problems, we're actively building a response. So these structural gaps, educational needs, lack of consistency maps onto our work. So from the core care pathway, which launched today on our new website, which I'll tell you a little bit more about soon, helps define roles and expectations for delivering pediatric palliative care across Canada. The resource hub that we've developed supports anyone involved in pediatric palliative care to be able to deliver this type of care. So this isn't theoretical. These are real deliverables that have been co-created by healthcare professionals and people with lived experience across Canada. Later this year, we'll be launching some communities of practice to help reduce silos. We're mapping networks of people across the country to help kind of connect the dots on where services are and where there are gaps. And we're developing tools and building awareness to support these early pediatric palliative care conversations. So it's introduced not at the end, but integrated from the start. A little bit about kind of the next, we call it the year ahead, but for now it's only the next 6 months. So the project grant currently culminates on March 31st of 2026, though we've got a request into Health Canada to extend it for another couple of years. We actually launched our resource hub as of today, www.pediatricpalliativecare.ca or soins palliatifs pédiatriques.ca. So it's a bilingual virtual platform that has both publicly available awareness building and education about pediatric palliative care in general, but also a resource hub that you can log into that has guides and curated resources to support a better understanding and support you in delivering pediatric palliative care. We launched the the Core Care Pathway for Pediatric Palliative Care, which was co-developed with providers and families that is this roadmap. So that's available on the website now. We have a map of all the specialty teams and hospices across the country that makes clear the provinces and territories that they support and how to reach out to them. Many of them have care pathways available to make how to refer clear, but those will all be up there within the next couple of weeks. We'll have care pathways and referral pathways for each of those specialty teams and hospices. In the next couple of months, we'll be growing our communities of practice, offering an asynchronous forum through the website for collaboration and knowledge sharing. And we're going to continue to bring awareness through conversations like we're having today, through conferences, through webinars, and throughout it all, we intend to stay very grounded in listening to individuals like yourselves and others who are doing this work and who are living pediatric palliative care needs day to day. I think next one is a picture. Yeah, so this is just a couple of snapshots. Thanks, Holly, for putting that in the chat, of the website itself. So as I said, it just went live this morning. So you can see here, we've got the snapshot of the map. There's a little snapshot of one of our guides, which is a pretty thorough overview of some of the really key topics that we found folks said that they were struggling with children's palliative care. So you can check those out, and a really great overview of what pediatric palliative care is as well. So that's just some snapshots on the site. And that's it for me. I think we're into the Q&A. Yeah. I don't know where to find the Q&A, Holly.
So if you do the three little buttons under more, then you'll see if you click on Q&A now. So far, just to let you know, there aren't any questions posted. So
Okay.
You have time while you look for it for people to start putting in their questions.
I found it. So if there are any questions, or if people want to unmute and share their questions about, Dave is happy to answer any questions folks might have that are a little bit more clinical, or either of us are happy to answer any questions about the Alliance, or hopefully everyone's just distracted going to the website right now and they're looking at it and you're just so engrossed in the content that.
I also have a question which can serve as a filler, but is hopefully also useful. So I'm in Ontario. I actually previously worked in family health team for 17 years, and so like I'm really really aware of those resources and everything, which is great. But I'm wondering about, let's say, some like a primary care provider who's not part of a fit, or let's say if they're in a province or territory with a different model. Is there any specific resources or different framework for those folks?
I don't know if you want to answer that one, or something else launched today.
There is a two-prong
Yeah.
answer to that, which is, how do we care for children of today and how do we care for the children of tomorrow? And we're trying, hopefully through work like this, to tackle both of those issues. For the children of today, it requires a coming together of who is present. And unfortunately, if there isn't a strong infrastructure in place and people who can make the connections and networks between specialist pediatric clinics that identify and care for children with serious illness and community partners, then the reality is that it is unlikely to occur in the way that we envision it and know it can occur. That doesn't mean that good care can't happen. And the truth is that without structures like this, that many children will receive good palliative care. They'll just receive that in hospital settings and often in intensive care settings. In fact, without palliative care infrastructures, the vast majority of children in children's hospitals even die in intensive care environments. And so thinking about how do we care more for the children of tomorrow, if and often it's case based that a case comes up and we realize, hey, we can't form these connections. We don't have a structure. We don't have a network. It requires raising the voices, ideally amplifying the voices of children and their families to identify the inequity that's present. Palliative care isn't perfect anywhere, and so we're certainly not looking for perfection. But what we shouldn't accept is when uh, care is impacted, when care is the obstacle is simply that they're a child. That's the reason why we can't make this happen. If this was an adult, this would occur. That's where we need to amplify the voices in saying that it isn't discrimination for the sake of discrimination. It isn't just because they're young. We understand that it's related to young people have different care needs, but how do we as a healthcare system turn around and look at so what are we doing about that? How are we considering that? How are we developing models and resources to support clinicians and that's thankfully through the national framework that was put forward a few years ago on the national framework on palliative care from Health Canada. And Ontario's done something similar here. I'm not sure about other jurisdictions. But it really calls for it doesn't say this is what every child needs and this is what you ought to provide. It's not commandments, but it is saying we need a strategy, and it doesn't start with perfection. It starts with how do we bring people to the table? How do we have these conversations? How do we achieve ideal and a path forward? And so there are whole provinces that don't have specialized children's hospitals and territories. And really it's communication and connections and networking with their regional centers and saying, how do we identify willing people? How do we identify educational opportunities? How do we identify backup supports from specialist centers so that we can make this work? And it's a decade's worth of work, and nobody was pretending that it's an easy answer. Akira, I don't know if you want to add to that. Otherwise, there was another question in the chat.
I think the only thing I was going to add, just because Holly, I know you'd asked specifically about Ontario, but there is a model of care for pediatric palliative care in Ontario that was just launched by the Ontario Palliative Care Network that I saw an email about this morning. So I've not had a chance to go into it yet today. But there are frameworks like this that exist in Ontario. British Columbia has done a lot. But one of the reasons that we created the core care pathway to help kind of outline what the expectation should be at every phase of the illness journey is because a lot of the provinces and territories have not had an opportunity to start to really consider what this care could look like in their provinces. And so it really lays a foundation for an understanding of what a journey can look like that can then be taken and adapted really to any setting at anywhere across the country. So that, like I said, is available on the website, and it's a bit of a read, but it provides an excellent overview of what care can look like in any setting across the country. I don't know, Dave, this is a you question.
Yeah. Well, the other thing I'll just add to that is that the provincial nature of healthcare is a real challenge um, for for pediatric palliative care, pediatric other things as well, but for pediatric palliative care, particularly because, not every province has a pediatric, tertiary hospital and are dependent on intra-provincial arrangements. And Ontario has launched this model of care that you could find through Ontario Health. If you put in Ontario Health pediatric model of care. It just went live today, but that required 3 years of work, and we have, 4 centers with specialist palliative care teams that, interdisciplinary experts that can contribute and put together, do the work. I don't expect New Brunswick to do that. It's not a criticism of New Brunswick. It's the nature of New Brunswick. So it's one of the reasons that we're so grateful to Health Canada to have identified this as a national issue, and it makes the work challenging on our, the national side to create things that work across provinces and aren't overly prescriptive or instructive, but supportive. Um, because we recognize the inequity across the province, across the country. And if we rely solely on provinces to solve their own issues, we are going to exacerbate an inequity instead of level the playing field. But it requires the foresight of groups like Health Canada to recognize that and support that, even when it would be easy for them to turn a blind eye and say, that's not the federal government's domain. We're going to leave that up to provinces. That would be easy for them to do, but the right thing to do is look at this as a national problem, and we're grateful that they have, and we hope that the work that has been put in by yes, pediatric palliative care specialist teams, but also generalists and a lot of we have enormous gratitude for our partners with lived experience that have brought their experiences to the table and have helped guide and shape that. So lots of gratitude from us today, but we do think that what has come out and what will continue to come out is going to be beneficial to guide some of that. Leanne, have you ever had a child whose parents don't want a DNR and have sent them home to die? I personally, I don't believe that's ever happened to me. And I mean, when we're having conversations about DNR and, we explain the role of it and what the difference of being in hospital versus being at home. And if you're in the hospital and your child arrests and you say, you know what, we don't want anybody to start CPR, then we can respect that. And in the home environment, you can't, right? That a variety of first responders, particularly in home nurses, will be obliged to start CPR unless the DNRC is present. And so with that explanation, I imagine it would be a very rare scenario, but I'm sure a scenario that has occurred where families say, "Yeah, but I don't want it." The In the worst case scenario, or in a scenario where it was completely unexpected and the family didn't have a DNRC, but or whatever the jurisdictional document is, but a palliative care team was present. I mean, one of the different advantages that I have, if I got that call, I could drive to the home and I could pronounce the child without starting CPR, whereas without the DNRC, a paramedic can't do that, a nurse can't do that, a firefighter can't do that, a police officer can't do that. And so it's never happened to me that a family's declined, and thankfully it hasn't happened to me that we didn't have the infrastructure in place and a child died and the family didn't call 911 and we were stuck in that sort of in between. We have had children die unexpectedly, but in all of those scenarios, 911 has been called. And so your question sort of maybe it's maybe it's hypothetical. It certainly sounds of someone coming from personal experience, and I'm sorry if you had that experience. That sounds like a very difficult journey, and emphasizes the importance of and the amount of work and emotional processing that goes into pediatric palliative care when families are making decisions that like often decisions that are in conflict with the medical team's recommendations or in conflict with basic logic, like we want a child to go home but we don't to die, but we don't want a DNRC. Like there's just a basic logical flaw. I find that healthcare often comes back at those families with logic and facts and information, expecting somehow to get through. Whereas usually the problem is a grief problem, it's an emotional problem, it's an acceptance problem, and it requires a lot of diving deep into what they're feeling and why they're feeling it, and doing that over time and throughout the journey, which is why it's so important to start engaging aspects of palliative care and the palliative care approach to care throughout the journey, not only for the child, but for their family as well. I see your answer there, but
And I
the,
will say there's a few, just poking everyone over to the resource hub. There are some guides on the resource hub that relate to how do we build resiliency in our pediatric palliative care workforce, and have some great sessions on self-care and support, because we know that not everybody has access to the same supports that we do who's doing this really difficult care in hospices and specialty teams. So you can head over and have a look at that. And as Dave said, some of the teams, depending on when you're located, are also available to be able to have conversations and offer pre-briefs and debriefs during difficult conversations.
That's great. I think maybe what I'll do, since we're nearing the end of the hour, is before I go to the wrap-up slide, I just want to highlight one of the great comments that we got in the chat. Someone said, "I love that it is child-centered and their wants and needs in palliative care and doing what makes them feel comfortable and not all about medical aspects, as it may be in the hospital setting." So I think these look like a really cool resources. So I just want to echo what you've been saying about checking out the resource hub. And when we share the slides and the recording, we'll include a link to that as well in case you weren't able to get to that. So I just want to thank everyone again for making time in your busy days to come join us and learn all about this really important information. And thank you, Dave and Kira, for your presentation. It was very enlightening. I had some shivers every once in a while. Just talking about the work that you guys have been doing. And we did share a link earlier on just to a feedback survey, and this will be helpful for us to review after the fact so we can see what worked and if there's anything we can improve upon. And we do have a couple sessions sort of loosely planned in the coming future. Kira, I don't know if I want to put you on the spot, but I thought if you could even just give a flavor of like what's being considered as some potential other focuses for these webinars.
We were going to do some outreach to try to figure out what it is that folks are really wanting to hear from us. One of the topics that really widely gets discussed, though, and what I would really like to talk about would be maybe perinatal palliative care. It's one of the areas of pediatric palliative care that sometimes is even less understood. And so that might be one of the sessions that we would think about, a focus on grief and bereavement, a focus on the psychosocial needs of children and families. So there's quite a few topics that we have been floating around to perhaps have at future sessions. Though based on some of the conversations here today, it sounds like talking about goals of care and advanced care planning, and navigating some of those difficult conversations around shared decision making would also be of a lot of interest as well. So lots of ideas popping around in our heads.
That's great. It sounds like some members of the audience are interested in those topics that you're considering. So everyone who's registered, we will keep you all posted with any new sessions and dates. So please do stay tuned for that. Thank you again to our wonderful presenters and to our audience. And I hope you have a wonderful rest of your day and almost finished your week. Take care, everyone.